Dr. Holbeach is an obstetrician and gynecologist from the Mercy Hospital for Women in Melbourne, Australia. She holds dual qualifications in law and medicine and has recently completed a PhD in bioethics on surgeons' legal and ethical obligations about surgical innovation, actually with our director of CBME, Professor Julian Savulescu, being one of your supervisors. Naomi is also the academic coordinator for learning and teaching and a senior lecturer at the Department of Obstetrics, Gynaecology and Newborn Health at the University of Melbourne, where she teaches students law, medicine, and ethics. So, without further ado, please join me in welcoming Dr. Holbeach, who will be speaking on confidence-based surgical innovation.
Thank you. Thank you so much for that introduction, and good morning to everyone. Thank you so much for the invitation to be here and to present to you my solution to some of the problems that I identified when looking into surgical innovation and how it's implemented into clinical practice as part of my PhD. So as mentioned, I am an obstetrician and gynecologist, and as a result of that, I've cared for patients who have been affected by surgical innovations, sometimes for better, sometimes for worse. I've also worked with colleagues who are performing surgical innovation, and during my training was involved in some of those procedures as well. And finally, as a clinical educator, I teach medical students regularly, not just about medicine, but about clinical reasoning and about their professional ethical obligations. And so these experiences led me to think about the role that surgeons play in surgical innovation. And so my solution, which I've called confidence-based surgical innovation, attempts to address some of the problems from that perspective. And it's a multidisciplinary framework that spans across medicine, ethics, and law, and considers the role that surgeons have in surgical innovation and aims to provide surgeons with a much-needed roadmap for responsible surgical innovation in clinical practice. Not clicking through. There we go. So just to provide a bit of an overview, I'll start by introducing the topic through a recent Australian case of Dr. Charles Teo. And then I will work through just very briefly some of the background to the problem and some of the issues that I identified in my work, just to, I guess, inform why I chose to go about the framework in the way that I have, and why I've called it confidence-based surgical innovation. I'm going to spend most of the time today, though, focusing on the framework, the confidence-based surgical innovation framework, and apply it to case examples taken from gynaecology. And I hope you'll forgive me for the heavy weightiness towards gynaecology, but that is what I live and breathe. All right, so some of you might know this person. This is Dr. Charles Teo. For those that don't, he's an Australian neurosurgeon who found himself the subject of a complaint about his care of two patients with brain tumours. He performed a radical debulking for both patients that other Australian neurosurgeons had deemed inoperable. And the complaints related to a number of matters, including his judgment about performing the innovative surgery, issues around informed consent, and also issues around his communication, including some breaches of confidentiality. Now, it went to the New South Wales Medical Professional Standards Committee, and they found that his professional conduct was unsatisfactory and placed restrictions on his registration. Now, some have argued that what he did wasn't actually innovation at all. And he certainly departed from established practice, but in the absence of an agreed upon definition of what surgical innovation is, there remains a little bit of debate. There were a range of complaints made, but the important one that I want to focus on today is whether he was justified in providing the surgery that he did to these patients. Now, the committee said no, he wasn't. And that was based on his peers not supporting the surgery. And the committee also agreed with the experts that the evidence he relied upon to justify his decision was weak. On the other hand, there were no curative options for either patient at the time. I want to put aside to one moment the serious issues of some of Dr. Teo's other behaviour and just focus on this question here of, was there a better way to approach this problem? And is there a way that we can offer innovative surgical solutions to patients that want them and do so responsibly? So in this background section that I'll briefly go through, the problems with surgical innovation that I've identified are that, one, there's no agreed upon definition of surgical innovation, which makes it difficult to recognise when it's happening. Another is that the obligations for information giving about surgical innovation are not patient autonomy enhancing enough to allow patients to make meaningful, informed choices about innovation in their own healthcare. Also, that courts and tribunals are inconsistent in the way that they review clinical decisions and therapeutic reasoning, and that makes the obligations that surgeons might have difficult to nut down. And finally, that therapeutic reasoning is an undeveloped area or underdeveloped type of clinical reasoning, especially for clinical questions involving limited evidence. And I think that cumulatively, all of these problems can be distilled down to two major issues for surgical innovation, and which is that surgical innovation is at risk of not happening when it should because of the lack of clarity around these problems, and also that surgical innovation does not reliably happen responsibly when it is happening. So, what is surgical innovation? Well, as I noted in relation to Dr. Teo, there's no agreed upon definition for surgical innovation, and this means that surgeons don't reliably recognise when they're doing it. And this leads to downstream problems because they may not take the appropriate additional precautionary steps when implementing surgery that's less known or uncertain. So to address this, I came up with a definition that was based on a body of literature across medicine and ethics, and also with reference to case law and disciplinary decisions, mainly in Australia and some from the UK, that have considered unconventional and innovative treatments. And I think of surgical innovation as an activity that is a novel departure from established care and that intends to improve health for patients. But I go a step further than that and propose three categories of innovation that then relate to the novel activity and the quality of the evidence that is used to support it. And these are three. So the first is entirely novel. So the example that I provided on the screen there is a Escher device. It's a contraceptive device that has now been taken off the market. It's entirely new. When it came out, there was nothing else like it. And so that would be an example of an entirely novel device. The second category is novel application. And so the example that I provide there is of vaginal mesh. Vaginal mesh is polypropylene mesh that was used extensively in general surgery for the repair of abdominal hernias and then translated into the pelvis for the treatment of pelvic organ prolapse by gynaecologists. And then the final example is novel variation. And novel variation is probably the most difficult of the three to really nut down, but this is when an established practice or procedure is varied in some way, either a variation that goes to the heart or the central character of the procedure that then takes it away from the evidence base used to justify it, or a cumulative number of small modifications or variations to a procedure that again takes us steps away from the evidence base that we're using to justify why it's safe and effective. And the example that I've put on the screen there is of the expansion and refinement of minimally invasive surgical techniques, and in particular, the example there is of robotic surgical systems. So when we're considering innovative practice, we need to understand the obligations that already exist for surgeons and how they might impact upon innovative surgery. Now, professional obligations are there to protect the public and in general can be found in codes of conduct developed by the medical board and various professional colleges. And I put some examples from Australia and from my own college of obstetricians and gynaecologists in Australia and New Zealand up on the screen. Notably for surgical innovation, and I refer to the Code of Conduct for Doctors that is from APRA, which is the registration body in Australia, that requires doctors to only provide care for which there is reasonable expectation of benefit. I think that's an important concept, and I'll return to that later as I start to work my way through towards confidence-based surgical innovation later in this talk. Surgeons' legal obligations, however, are generally found in the law of negligence, and these obligations offer patients compensation for the harm suffered because of surgeons' negligent actions. And the standard is reasonable care and skill that might relate to information giving, but also to diagnosis and treatment. But it's not clear how to meet the standard and innovate responsibly. And in my analysis, I conclude that with respect to the duty to warn, the obligation is too narrow to support patients when making decisions about innovative surgery. But I suppose most importantly for today's talk, I also conclude that courts and tribunals are not consistent when they're reviewing therapeutic reasoning. And this is a problem that I'll focus mainly on today, but I will circle back to the issue about informed consent a bit briefly later on. And this leads to a range of unanswered questions about how to make clinical decisions about surgical innovation. One of them is that it's not clear who our professional peers are, especially in surgical innovation when it may involve a very niche area of clinical practice, and it might also involve international expertise. And in some jurisdictions of Australia, international expertise is not admissible as part of expert evidence. Whilst it is clear that there's an expectation of peer support and collaboration, it's not clear how to resolve professional disagreement and dissensus. And then finally, it's not clear how confident the surgeon must be in the evidence to justify acting on it and providing the surgical innovation. And so what I try to do with confidence-based surgical innovation is address some of these gaps. Now, confidence-based surgical innovation is certainly not the first time that someone's tried to put together a framework for dealing with these complex issues in surgical innovation. And other attempts at guidelines have not addressed these problems and offered a clear enough roadmap for surgeons so that they know how to get from step A to B to C and then decide whether or not they can responsibly implement surgical innovation in a particular instance. I want to highlight a few of those guidelines now. One of them is the IDEAL framework, which provides a structured approach to managing surgical innovation that champions evaluation of the innovation at every stage from development to implementation and beyond. But there are certainly other examples that I've pulled out here as well. And these guidelines canvass the ethical matters generally. The Royal College of Surgeons guideline in particular provides a flowchart that I think is quite helpful, but still all of them lack a lot of detail that would be very helpful to surgeons who are trying to understand what their obligations are and what to do. So there are still some unanswered questions relating to how confident we should be in the evidence before acting, how to think through a decision to offer innovation or not, and finally, how to implement innovation in a tailored way, accounting for the risk profile of a particular innovation. So it boils down to good reasoning. The guidelines have not clarified how to do this for surgical innovation. Courts and tribunals, when asked to review therapeutic reasoning, do so inconsistently. But what is therapeutic reasoning and what does it look like in clinical practice? Well, clinical reasoning is how doctors collect, evaluate, interpret, and synthesize a range of information to make a clinical decision. And it may relate to diagnosis, prognosis, and treatment. Now, each of these three types of reasoning are different, but they're interrelated and all together are fundamental to good medical practice. Diagnostic and prognostic reasoning are not relevant here because we're concerned with treatment decisions primarily. And this is what therapeutic reasoning does. It describes how doctors develop a management plan that includes plans involving surgical innovation. Now, most therapeutic reasoning relies on applying evidence-based medicine principles. And that involves taking the evidence and integrating that with clinical expertise and patient values to arrive at a decision. And it can present a challenge to surgical innovation when the evidence is lacking or low quality or indirect. Is it possible then to think well about innovation in these situations? Is it possible to offer innovation in these situations? And how can doctors reason well when their usual reasoning tools, that is, evidence and peer support, are limited? So I think philosophical reasoning can help us out in this situation, and improve the quality of thinking in situations where evidence is limited. I've mapped the level of evidence, including ideas and expertise, to different types of philosophical reasoning. And here are some examples. I found that when surgeons and innovators are developing and implementing innovation, they rely predominantly on abduction or induction. Now, abduction is characterized as a best guess and often comes from very weak evidence or unsubstantiated ideas, but it's a really important type of reasoning that generates new ideas and hypotheses. Induction, on the other hand, is a reasoning type that infers conclusions based on observed data. And some examples are reasoning by analogy and statistical generalization. Now, when there's some evidence, surgeons either reason by analogy if the evidence is of low quality, or by statistical generalization if the evidence is of a higher quality. But some of the problems happen when the wrong type of reasoning is used, and then we put too much faith or too much confidence in the conclusions that we draw. I think a good example of this was with vaginal mesh, where the evidence from general surgery was translated into gynecology without accounting appropriately for the differences in anatomy, the differences in indication, and the differences in the population groups. And it's possible then that some gynecologists placed too much weight on the evidence from general surgery when they made that translation into gynecology. I think we can agree, though, that estimating the strength of our conclusions accurately is important. And it's important because it informs how much we believe the innovation will be effective and safe when it comes to making good decisions. So, how much should a surgeon believe in the benefit of an innovation before they are justified in acting on it? Well, I draw on the philosophical concept of degrees of belief and confidence in trying to sort out this problem. Belief is something that sits on a spectrum, and how much we believe it depends on the strength of our conclusions. And it's related to this philosophical concept of confidence, which is how much we believe in a thing. Now, Richard Foley proposed a threshold of confidence beyond which we're rationally justified. And this conception of confidence offers a helpful way to structure decisions made at the limits of evidence. However, it requires resolving the problem of determining what that threshold actually is. Now, Foley didn't think it mattered precisely what the threshold was, only that we applied it consistently. And I think that we can sort of nut out what the threshold might be in individual cases by relying on professional collaboration and debate and informed by our legal and professional ethical obligations. And so I adopt this concept of confidence into confidence-based surgical innovation. So we're going to move on now to what confidence-based surgical innovation is, and then applying it to some examples. Okay. So I propose confidence-based surgical innovation, which is a three-part framework for surgical innovation. Step one is categorization. And that is a process for recognizing surgical innovation and categorizing the type of innovation so that surgeons can start the process of reasoning well right from the outset. Step two is assessment, a process for assessing the benefit of the innovation and then assessing the risk level of that innovation so that we come out the other end of step two with a risk profile. And then that takes us directly into step three, implementation. And this provides then a tailored response to the risk level of the innovation and enables responsible surgical innovation. The pitfalls of surgical innovation that I think this framework addresses are, firstly, problems around recognizing surgical innovation. Secondly, problematic assumptions that variations to surgery, established procedures in surgery are inherently low risk. And then also uncertainty about how to implement innovation in a tailored way. I think the major contribution of this framework is that it expands the process of novel application and variation and develops a more nuanced understanding of how to manage low and moderate risk levels of innovation, which doesn't yet exist. All right, I'm going to step through each of these parts separately and explain why I've gone about structuring this framework in this way. So step one, recognising and categorising surgical innovation. And it asks surgeons to really interrogate what they're doing by asking a series of questions and then prompting them to perform a literature review. So the first question is this a departure from established practice? And if it is a departure from established practice, is it novel? If it doesn't answer those two questions, it doesn't belong in this framework, so it'll have to exit right here. Then the next step is to look at the evidence. So we ask surgeons to identify and then assess the evidence, and we do that using the Oxford Centre of Evidence-Based Medicine table of level of evidence. So the levels of evidence in that table are level 1, 2, 3, 4, and 5. So level 1 being systematic reviews of randomized control trials, as an example. Level 2, you might see randomized trials or observational studies with dramatic effect. Level 3 is non-randomized control cohort studies. Level 4 are the case series, the case controls, historically controlled studies. And then level 5 is mechanistic reasoning and clinical expertise. So not really evidence, but might be part of piecing together why we think or believe something about a particular surgical innovation. Then the next part is to assess for indirectness. Now, I apply the GRADE guidelines, which is a system used to develop clinical practice recommendations based on evidence, and suggest and the guidelines suggest that developers account for indirectness of evidence by rating down the quality of evidence. And I adopt the same principle here. It's especially relevant to novel applications, and I guess to describe how it would operate is going back to the vaginal mesh example there, if you have evidence that is coming from a different patient cohort or for a different indication, then the GRADE guidelines would suggest you rate down, say, if you had level 2 evidence, you might rate that down to level 3. It's not particularly clear how many levels they suggest rating it down, but that's the process that they advise. So we downgrade as required, and then we assign a category of surgical innovation based on a best fit. So taking into account what the novel activity is. Is it a brand new thing? Just if you sense check it and just think about what you're doing, does it sound like it's a not entirely novel thing? Or does it sound like you're taking something from somewhere else and applying it into a new clinical context? And then sense checking that against your literature review. So if there's really no evidence out there, then it's probably going to be entirely novel. But if you've got some evidence and it looks like you're translating something from one set to another, then maybe we're looking at a novel application here. My advice really is that when in doubt, upgrade. So if you're not sure if it's a novel application, a novel variation, my suggestion would be call it a novel application, because it'll be a much more rigorous assessment as we move into the next part of the framework. So step 2, assessment of surgical innovation, asks the surgeon to then think about benefit and risk separately, just for clarity. First, there must be a reasonable expectation of benefit, and I'm just harking back to that code of conduct comment that I made in an earlier slide. Then if that part is satisfied, that there is going to be some benefit to doing this, then we can undergo a risk assessment. So starting off with step 2A, benefit. The first question the surgeon has to ask is determining if the primary benefit can be met with sufficient confidence. The primary benefit is what the surgical innovation is supposed to do. If it doesn't meet the primary benefit, then there's really no point in continuing. In the case of uterine transplant, which is a procedure used to restore fertility to patients who don't have a uterus, the primary outcome is a live birth. So a successful transplant, or the ability to have to transplant and then get pregnant, but then not result in a live birth, doesn't meet the primary outcome of the innovation, and so it fails. So we begin by analysing the literature with respect to efficacy of the primary outcome, and then decide how confident in the literature we can be. Sorry, next one. Confident in the literature we can be based on the level of evidence that we've got. So if we look back at some of the disciplinary decisions, and I'm speaking mostly from the Australian context, they have a low threshold for confidence. It was actually quite surprising when it comes to what is a reasonable expectation of benefit. And There were only limited decisions that actually specified the type of evidence that they were relying on, but those that did have indicated that level 4 evidence, and to remind you, that's case control studies, so pretty low level evidence, is reasonable as long as other precautionary steps are taken. But the level doesn't have to be locked into level 4. It can and should be debatable to an extent amongst expert colleagues and also taking obligations into account. But as I move through today's talk, I'm just going to use level 4 as sort of a threshold test case for applying to different case studies. If we're not confident in the evidence that we've got, then we should offer an alternative. But if we are, then we need to consider secondary benefits. Now, secondary benefits might be less pain, less bleeding, shorter hospital stay, more aesthetic result. And the reason is that surgical innovation is only justifiable outside of a trial if there's some additional benefit to the patient. Otherwise, the established practice should be preferred. Now we move into the next step, which is assessment of risk. So once you've got a reasonable expectation of benefit, I propose a risk score algorithm that incorporates level of evidence with incident severity ratings. Now, incident severity ratings, or ISRs, are a well-known tool that we use to categorize harm, especially in the context of triggering risk management systems. Now, I don't use it to imply that there should be risk management systems triggered every time we apply this algorithm, but it was a well-known and user-friendly system that that we could adopt into this framework that doctors would understand intuitively. So we again evaluate the evidence here. We have a look at the evidence that we gleaned in step 1 and that we also used before in step 2A, and we decide, what does it tell us about possible harms? Now, if the evidence was a level 5, then I suggest that this is considered a high-risk surgical innovation. Okay, if we're just basing our decisions about risk off mechanistic reasoning and clinical expertise, I don't think that is strong enough for us to categorize that as anything other than high risk. If there is some evidence, so level 1, 2, 3, or 4, then we need to have a look at that and then decide what is the severity of the harm that appears in that evidence. And so ISR 1 is severe injury or death. ISR 2 are moderate injuries. So that could be a severe infection, for example, or pressure sores would also be counted in that. And ISR 3 is mild injury. So that might be, a UTI that's treated with antibiotics on the way out of hospital, or no injury at all. And then we need to decide how confident we are in that evidence, and whether we need to upgrade the level of risk based on our confidence. So if we have a look at a moderate injury, so we've had a look at the studies, we had a level 3, say a prospective cohort study, and it said that there was, there were patients that had, pretty bad infections and hemorrhage. We might say, okay, that's ISR 2. We have sufficient confidence in that, and so we're going to proceed on and call that a moderate risk. Now, if we had, for example, weaker evidence, or we had to downgrade that level 3 evidence because maybe it was in an animal study and we've decided actually we're going to downgrade that to, say, level 5, then we're not so confident in that, and so we would upgrade to a high risk surgical innovation category. And we can do that for both the low risk and the moderate risk, but we can't downgrade our risk level. So you can't go from high risk down to moderate risk or moderate risk down to low risk. You can only go up. After exiting that risk score algorithm, we need to put it in context. So at the moment, we've really analysed the innovation from in an abstract sense. Now, the surgeon must assess whether the risk profile holds in the setting that they propose to use it. So for low and moderate risk, a reevaluation of the risk level occurs based on any factors in the clinical setting that might increase that risk. So, and some will be modifiable, like surgeon training or training the surgical or the operating team. Others may not be. So severe conditions or comorbidities might not be modifiable. If it is modifiable, then we should modify it to reduce the impact and then reevaluate that risk level again. And then before proceeding on to step 3, implementation. For high risk innovations, we proceed directly to step 3. We bypass all of this because we don't have any evidence. So it's just going to stay high risk. So now that we've got a risk stratification of the surgical innovation that we're hoping to use, we need to work out how to implement it and what level of precaution is appropriate for the risk level. For low risk innovations, I propose standard precautions. And these are, there should be informed consent. None of this is going to be particularly surprising. Training for the surgeon and the surgical team, standard follow-up and documentation, and evaluation, which could include audit. It could also, include publishing case reports in journals as well. The details on informed consent I will cover on my next slide. For moderate risk innovations, I suggest all standard precautions plus the following, which is that informed consent should also include pre-approved patient information. There should be some oversight and approval process. There should be a mandatory second opinion, extended patient follow-up, and extended medical record keeping. And I added the last two, the extensions on follow-up and record keeping, based on the Senate inquiry in Australia for vaginal mesh, which noted some of the extremely delayed periods that patients had adverse outcomes unrecognised, which meant that they were lost to follow-up in a lot of cases, which worsened their outcomes and certainly worsened their feelings about the medical profession. In terms of informed consent, I suggest that informed consent, standard precautions for informed consent include explaining that the surgical treatment is novel, that it means that it's less known and less certain, and that might include discussing the level of evidence that's available. Inform the patient about known and unknown risks. Inform the patient about known or expected benefits, inform them about the surgeon's experience and training, inform the patient that there are established alternatives, and provide a comparison of risk and benefit between the novel and established treatments. And then finally, of course, disclosing any conflicts of interest. And then for moderate risk innovations, additionally, offer the patient pre-approved written information and a repeat appointment to rediscuss, and consider a cooling off period, which came directly from the Dr. Teo case. Finally, mandatory second opinion. So notably, high-risk innovations that have bypassed the whole assessment step in the framework, and that's because we don't have any evidence used to assess. Now, these innovations should be presumed to be high risk, and the default position is to offer an alternative treatment and do research first, or enroll the patient in a clinical trial. However, I do make allowances for mitigating factors, so the patient factors or significant secondary benefits that might mean that we would be doing harm by not offering the high-risk surgical innovation. But this will be a decision on a case-by-case basis. And if it does turn out that we agree to do the high-risk innovation in these very exceptional circumstances, then the additional and standard precautions would apply as for moderate risk. So I suppose to explain this a bit more fully and demonstrate how this might operate in practice, I draw on a hysteroscopic resection, which is a procedure well known in gynecology. It's a minimally invasive technique that's used to treat a range of pathologies located inside the uterine cavity. Examples of those might be fibroids and polyps, which are generally benign growths, or retained products of conception after a failed pregnancy. The tissue inside the cavity can be removed using a long, thin camera called a hysteroscope, and it's pictured here, that enters the vagina, goes through the cervix and into the uterine cavity. Now, the resectoscope is an energy-bearing device that shaves off small chips of and you can see that sort of in the very middle picture there, shaves off small chips of the pathology and takes them out. Now, it doesn't have any evacuation mechanism. So what that means is, as a gynecologist, you start chipping away at this pathology, and the whole cavity just fills up with chips of debris, and you lose visualization, and you have to pull everything out, evacuate the debris by using a little catcher, which is kind of like fishing inside the cavity, and then re-enter the device. Now, for very large pathology, that's a really not just annoying, but also high-risk thing to do, because every time we introduce the device back into the uterus, we can damage the vagina, the cervix, or perforate the back of the uterus all over again. And I like to say that we're very careful not to do those kinds of things. But certainly it's happened. And so it would be nice if we could just evacuate at the same time without having to continually reintroduce our device. There is another device on the market called a MyoSure morcellator, and that is not energy bearing like the resectoscope, which means that you can't cauterize vessels that are bleeding if that happens during the procedure. And it works by mechanical destruction but it has an evacuation mechanism. So it basically chews, grabs, and pulls it out all at the same time. So when as gynecologists, we have to kind of make a decision. If it's a really big pathology, we think it might bleed, well, then probably use a resectoscope, but accepting that it's going to take a long time, and the longer our operation lasts, the higher the risk to the patient. Sometimes we have to come back and do a procedure multiple times because we haven't been able to do it in the allotted time. So I had a bit of a think about this and decided, well, what would be a nice solution to this? And I came across this device from urology called the ELIC device. It's a really rudimentary extraction device that works by creating negative pressure to vacuum contents, and it's used in urological surgery. So, for example, when they're doing prostate surgery, they attach it to the cystoscope. A cystoscope is just the same thing as a hysteroscope, except it goes into the bladder instead of the uterus. And it evacuates the contents at the same time. It's been around since the 1950s, and it's pretty cheap. So I had a bit of I went through this process, thought, yep, this is a novel departure, and I'm going to go and have a look at the evidence. I did my literature review, and I found one case study exactly like I intended to use the ELIC device in gynecology that was published in 2023. It was successful. It shortened the operating time, and there weren't any complications that they noted for their patient. There was another one from gynecology that involved evacuation of blood clots from the bladder. So that's used almost identically to the way urology does it. It just happened to be in the gynecology literature. And then if you go into the urology literature, there were a number of case reports, so all level 4 evidence we're talking about at the moment, except one prospective cohort study in urology that was level 3 evidence. And again, it worked very well. They didn't have many complications except for some UTIs that they treated with oral antibiotics on discharge. So I thought, okay, best fit here. We're translating this from urology. There's certainly evidence from urology, and it's the best I've got is level 3, but it's in a different setting. So I'm going to downgrade that to level 4 evidence. And now I'm going to end and say this is novel application in my step 1 categorization phase, and I'm going to move into step 2. So then for step 2, novel application, I need to ask myself now, whether does the innovation offer the primary benefit? And in that gynecology case study, it definitely did. And in all of the urology studies, it certainly did as well. It evacuated, it saved them surgical operating time. And I think at level 4 evidence, we can say sufficient confidence. Does the innovation offer more benefit than the established practice? Well, yeah, it shortened the time, which means you can actually get through more of the procedures. And it also means less operating time, less anesthetic time for the patient. Those are good things. So now we're going to think about the risk assessment, and we're going to go into the risk score algorithm, which I think is on the next one. Okay, so what is the evidence about the possible harm? So as I said, I could only find evidence that there were some UTIs that they treated, so urinary tract infections that they treated with oral antibiotics. That was in the level 3 evidence that I downgraded to level 4. So we're going to follow the red box right across the screen here. I'm going to use my marker because that'll be helpful. What was the severity of the harm? I said it's ISR 3 for a simple UTI that was treated effectively with oral antibiotics. How confident? We'll go back to level 4. So, yep, we're confident. So we're going to end up in this low risk box down the bottom here. And we're going to take that through to step 3 implementation. So we've said that low risk means we're going to apply standard precautions. We're going to do informed consent, as I outlined earlier. We're going to make sure there's training for the surgeon and the surgical team, and that might mean playing with the device before the operation. Make sure that we understand how it needs to attach to the hysteroscope. Make sure we understand if we need adapters. Make sure we're all on board about when we're going to bail. Is this going to, if we can't get it to work after how many attempts, who's going to say to the surgeon, look, I think we need to possibly go back to standard practice because it's not working today. We'll revisit another time. Standard follow-up, standard documentation, and then evaluation. So we're contributing to the growing literature about this possible solution to a gynecological problem. Then I got a little bit more creative and thought about, well, there's the MyoSure morcellator that's really nifty. It's quite a good device to use. It's very quick. And maybe if I added some energy-bearing type technology to it, I'd be able to use the same device that works very well, but also cauterize vessels if I happen to see them. And that would then allow this MyoSure device to be expanded for use in, say, really large fibroids, pathology where we're concerned about bleeding, where currently it's probably not the right device to use. So is it a departure from established practice? Yes. Is it a novel departure? Yes. When I went through the evidence, I did do a pretty detailed search for the evidence, for any evidence actually, and could find no such device on the market. I searched Medline, Embase, PubMed, Abesco, all of the things, found no similar devices. I then adjusted my search terms to expand to complex hysteroscopy, thinking that perhaps there might be some developments on the market, but unfortunately, no. I did get a range of good quality studies and guidelines in that search, but they were all using existing devices, the resectoscope and the MyoSure. So I think I was pretty comfortable we could come out of step one with an entirely novel categorization of this device. Because it's entirely novel, it then bypasses the assessment step, okay? Because there's no evidence that can tell us about its benefit. It's all going to be mechanistic reasoning. And there's no evidence that we can rely on to try and assess whether or not what the risk level is. So we're going to assume that it's high risk, move through step two into step three, and then ask ourselves at this point, look, are there any mitigating factors or secondary benefits or patient factors that might create an exceptional circumstance where we might use this for a patient even though it's high risk and we don't have enough evidence yet? And I think with this particular device that I've invented, the nature of the device as an energy-bearing device that is going inside a body cavity probably makes it quite high risk. And then the second being the nature of the condition, which is generally the treatment of benign fibroids. This is not a life-threatening problem. And so I don't think that there would be any exceptional circumstances that could justify using this outside of a clinical trial. But you might compare this to, say, Dr. Teo's patients who had no other curative options available to them. And so if we did apply the same framework to Charlie Teo that I mentioned at the beginning, I think we would still end up in a high-risk category because there was no evidence that was available to support the radical debulking that he performed on those two patients. But we might have been able to get to this step in step three of implementation and argue that in the absence of any other alternatives for these patients, perhaps on a case-by-case basis, it could be considered. I don't know how that might have come out in the end, but if we did come to the conclusion that yes, we can proceed with this surgery, then additional and standard precautions would have applied. And I think that's really what was missing in Dr. Teo's case. So the informed consent, the additional precautions of mandatory second opinions, ethical oversight, all of those things weren't applied in his case. So the framework still has its limitations. It doesn't solve every problem that surgical innovation challenges us with. One of the limitations, I think, is still around the definition and recognition of surgical innovation and what it is. I think there are still ways that surgeons can underestimate the innovative nature of what they're doing. And if we think back to the ELEC device that I proposed just a few slides ago, It's a remarkably simple device that involves a glass connector. It's got a squeeze bulb and rubber tubing. It's connected to a resectoscope. The simplicity of it and the fact that it involves no energy or power source, doesn't enter the patient's body cavity, it actually stays outside, might cause some surgeons to consider it too simple or too low risk to be an innovation. And also the fact that it's been adapted for urological use, also it appears in cardiothoracic surgery and gynecology, it might lead some to conclude that it's not novel surgery, not novel to surgery generally, and therefore not innovative at all. So there's always capacity for, I think, people to underestimate what they're actually doing. And so the framework tries to ask people if there's any doubt to just assume that it's innovation unless you've got very good evidence or reason to say that it's not. Another limitation is the problem of indirectness, and the grade guidelines are vague. It suggests downgrading the level of evidence by 1 or 2 levels, doesn't really provide instructions about how to do that. It appears, if it's a human study and you want to downgrade it by 1 level, if it's an animal study or an in vitro study, then, maybe we downgrade it by 2. But it's not really very prescriptive or clear about how to do that. And then finally, not really a limitation exactly, but I just want to acknowledge that not all health services have the capacity to provide the necessary oversight through a new procedures committee that I actually require in this framework. However, I think responsible surgical innovation demands this type of investment, and without it, surgery remains at risk of both the problems that I raised at the beginning of this talk, which is that it won't happen when it should, and it won't happen responsibly when it does. Despite this, I think that there's reason to be excited about the potential for competence-based surgical innovation as a framework, and also for therapeutic reasoning more generally. So I developed this framework with surgeons predominantly in mind, but there is broad potential for other stakeholders involved in surgical innovation decision-making to adopt this framework also. So new procedures committees, hospital review boards, medical indemnity insurers can all benefit from a systematic approach like this to assess a proposal for an innovative practice. Courts and tribunals could also adopt this framework when reviewing therapeutic reasoning in relation to claims. And I think that consistency about expectations of what is needed to rationally justify innovative practices promotes surgical innovation by removing the guesswork and the uncertainty of current review processes. Even more promisingly, the framework could be adapted to apply to all departures from established practice. So patient preferences, patient goals and values sometimes challenge us as doctors to provide care that moves away from evidence-based practice and consensus recommendations. And a confidence-based approach offers a systematic way to think through these departures clearly and provide safe care and be able to communicate that to both our patients and to our colleagues, and then potentially to courts and tribunals if it came to that. Finally, recognising that therapeutic reasoning is an underdeveloped but critical part of good medical practice, I propose that confidence and philosophical reasoning is integrated into therapeutic reasoning generally, and recommend that more research is done to further this area in the literature. Thank you very much for your attention. Happy to take any questions.